So we're going to get started. We are joined today by Dr. Kelli Baum. She's a board-certified orthopedic surgeon specializing in joint replacement. She focuses on primary and revision hip and knee replacement, minimally invasive solutions to hip and knee replacement, anterior hip replacement, and patient-specific instrumentation. She is fellowship trained at Wake Forest Baptist Hospital in North Carolina. Kelli joined Samaritan to give back to the community that she grew up in and did her medical school and residency training. And then Dr. Ryan also joins us. He is also a board-certified orthopedic surgeon specializing in joint replacement. He focuses on primary and revision hip and knee replacement, minimally invasive solutions to hip and knee replacement, computer navigation, and patient-specific instrumentation. He is fellowship trained at the Hospital for Special Surgery in New York, and he considers his ability to restore pain-free mobility and increased quality of life to his patients as a blessing. So at this time, I will turn it over to Dr. Baum and Dr. Ryan. Thank you very much.
Thank you. I just want to confirm everyone can see the presentation at this point.
Yes, we can.
Okay, perfect. So we'll go ahead and get started. Just a quick, for those that aren't familiar with the format with Teams, on the right-hand side of the screen, there should be a little chat box, which you can go ahead and put some questions in there. Again, we just ask that everything is muted so that there's no background noise for everyone listening. So obviously we were just introduced. I'm Kelli Baum. I think that introduction was appropriate. I live here in North Albany and with my family, and have been an active member of the community since my training. And my background is as was discussed. Dr. Ryan, is there anything you wanted to add about yourself?
Well, I'll just add that since fellowship, right after fellowship, I moved to Corvallis with my wife, Michelle Ryan, who's a rheumatologist. We've been here for 12 years. I practiced exclusively in Corvallis for 9 years and operated a Good Samaritan. And then 3 years ago, transitioned to Albany General Hospital with hopes of creating the joint replacement program that you're going to learn about right now. I have 2 kids and love living in Oregon and being a part of this community.
Great. So we'll get started. Just a kind of a brief overview of what it is that we do. Obviously, we're both orthopedic surgeons. We perform hip and knee replacements, as well as revisions or fixing sometimes hip and knee replacements that have problems or issues. Our joint replacement program here at Samaritan, which is centered out of Albany, offers something which we think is pretty special to our community. We have a special certification through the DNV, which is who certifies our hospital, and we're going to talk about that later on. It deems us as a center of excellence for joint replacement. We provide minimally invasive both hip and knee replacements, Dr. Ryan and myself. We use technology, and again, we'll go into this more, but we offer customized patient instrumentation. We use computer navigation. We offer anterior hip replacements for those that have done any research into the different kinds of ways that hip replacements can be done. We use computer-assisted surgical planning. We have dedicated care teams, therapists, nurses, aides, all hospital staff that participates in caring for our joint replacement patients are specialized in doing so. With hip and knee replacement that we do here, between Dr. Ryan and myself, we perform anywhere between 15 and 20 joint replacements or revision joint replacements every week. We use, like I said, technology to improve outcomes and give our patients the highest level of care. And again, we're going to go into some of this stuff in more detail, but that's currently sort of what our practices look like today here in Albany. So to start with, we want to go over both hip and knees, the anatomy, so that everyone sort of knows what it is that we're talking about. We'll look into arthritis and what causes those joints to break down, and then the treatment options, not just surgery, but other things that are available. And then more detailed about what goes on with hip and knee replacement. And we'll have lots of time at the end for questions, and you can feel free to put some of those in the chat if you don't want to forget them. We'll get back to them later on. So looking at the knee is comprised of the thigh bone up above, or the femur, and the shin bone or tibia down below. And there's ligaments on the inside and the outside, or what we call the medial and lateral aspects of the knee, that give the knee stability. There's a kneecap, obviously, that sits in front of the knee, and that tracks through a groove on the end of the thigh bone. And all the surfaces of those bones are coated with cartilage. The knee, in its most simplistic form, is a hinge, but it moves in other directions. It rotates, it pivots, and it slides. And in between the ends of those bones, not only is the cartilage acting as a cushion, but there's a cushion inside called a meniscus, and that helps to stabilize the knee and distribute your weight. And on the inside of the knee, there are two ligaments as well. One's called the anterior or the front ligament, and one is the posterior or back ligament. And those give you stability front to back. The hip joint, similar but different. It's a ball and socket joint. It's comprised of the top of the thigh bone, or the femur, called the femoral head. And then inside the pelvis, or is the cup, or what's called the acetabulum. And those, again, are coated with cartilage. That's what gives it its cushioning and allows it to move smoothly. And it's surrounded by stabilizing ligaments in a very thick, dense capsule. The similarities between the joints are, obviously, the surfaces of the bones are covered with cartilage. There's fluid inside of that called synovial fluid, which helps those surfaces move smoothly together. And we walk on them. Different from a shoulder, we walk on both our hip and our knee, so those are considered weight-bearing joints. And arthritis very significantly affects both of these areas. So what is arthritis? It actually comes in many forms. The most common type that we see is called osteo or bone arthritis, and that's the typical wear and tear arthritis that happens over time. The lining of the joint or that cartilage becomes eroded and pitted and wears thin to eventually a point where you have the bones rubbing against each other and no space in between, as you can see in this picture here. And this makes common activities extremely painful. Standing and working in the kitchen, going on short walks, playing with the grandchildren, all those things become hard to do. It typically affects those in their 60s or later, but oftentimes we'll see it can affect people down into their 40s. The most common symptoms, obviously pain, pain within the joint itself. You often see swelling as well to accompany that. When it gets more severe, it's not only pain with activity, but pain at rest that can disturb things like sleeping. Again, stiffness, swelling, loss of motion in the hip and knee are all things that become more difficult. Something we take for granted, like putting on your shoes, can become very hard if you have severe hip or knee arthritis. So the treatment options fall into two categories when we're talking about arthritis, and that is non-surgical treatments and surgical treatments. So we'll start on the non-surgical things. Those come in many flavors, changing what you do, losing weight, exercise, medications, and injections, and we'll touch on each of those. So there's a lot of research that shows that exercise can be one of the best things for arthritis. Remaining active, keeping the joints moving, helps with pain, believe it or not. So it helps with improving your flexibility and also keeping your weight down. As we know, the more weight that we carry, the harder it is on our hips and knees. And so maintaining a healthy weight is beneficial both for managing and dealing with the pain of arthritis. It also makes any potential surgery safer when you're at a healthy weight. Medications. The mainstay medication for most arthritis, because inflammation is one of the culprits of pain, are anti-inflammatories or NSAIDs, non-steroidal anti-inflammatories. Those are things over the counter such as Advil, Aleve, or Motrin. Not everyone can take those based on other medical conditions, but if you're able to, that's a mainstay treatment. Tylenol or acetaminophen also is very helpful with pain. There's a myriad of topical creams, sprays, and ointments that also can be used. And then there are injectable medications, and those come in different flavors. For knees, corticosteroids are one of the mainstays. And then hyaluronic acid, more commonly referred to as rooster comb or lubricating injections. Again, those come in many different flavors. Typically, it's a series of 3 injections, but there's some newer formulations that provide single shots. Those are only approved for knees currently, but both injections can help to alleviate the pain in both the hip and knee due to arthritis. And then for knees in particular, there are certain patterns of arthritis or types of arthritis that benefit from a brace. I'm sorry, this is the viscosupplementation, that rooster comb medicine, is only approved in knees, which I touched on. But additionally, there is a brace that is approved for certain types of arthritis that helps with pain that comes on with activity, primarily walking or light exercise. Obviously, there's no brace for hip. You'd have to pretty much brace your whole body to get something up that high. So when those things are implemented and tried, and a patient no longer is receiving symptom relief from non-surgical treatments. They have pain every day, pain that affects their quality of life, and pain that is making it difficult for them to do things that they enjoy. That's the time that we consider joint replacement. So we'll start on touching
Hey,
on knee
Kelli,
replacement. Yes.
I'm going to interrupt you for just a sec, just to add a few things to the non-surgical care.
You
So
bet.
if you could go back, so that viscosupplementation, or the series of 3 lubricant shots, although we predominantly do that in the knee, we are doing that in the hip more frequently now. And we do have providers in the Samaritan system that can offer that and that can be successful for some patients. So that's something that's a little bit newer in the last year or two. In addition to that, what Kelli has outlined are the treatments that are generally recommended because the medical studies that we have support their use. However, there are a lot of other options out there, and I always like to reference them because some people may benefit from them, even though our medical studies don't support their use and they're often not covered by insurance. And that includes things like stem cell treatments, acupuncture, electrical stimulators, over-the-counter formulations like glucosamine, chondroitin sulfate. There's about 100 different things. You'll see commercials on TV with Brett Favre and Jerry Rice playing with copper knee sleeves and feeling like they're 15 years old again. Those types of things can be tried, and there certainly aren't detrimental, detrimental, but medical studies really don't support their use overall. So I get a lot of questions about those things, so just wanted to comment on that. Thanks.
Yeah. So we'll start talking about knee replacements. And for this talk, we're focusing on a total knee replacement, which means replacing the whole knee. There are some patients which may be a candidate for what's called a partial knee replacement. We won't go into the details of that right now, but that is something that's out there that you may or may not have heard about. The full knee replacement is where all the damaged parts within the knee are removed with metal and plastic. And the damaged surfaces of the bones are essentially excised. So this kind of walks you through the process. Here we have a knee that's worn out. The cartilage is completely destroyed. And we'll talk about the specifics of how we place these parts. But the ends of the bones are essentially shaved off. And I equate this more like recapping a tooth. We're not cutting through the bone, removing the whole end of it. We're really just removing in a very precise way the thickness of the metal cap that goes onto the end of the bone. So we try to leave as much of your bone as possible and just remove the damaged surface. The same thing is true on the top of the shin bone. We remove just the top destroyed cartilage. And then we place a new metal cap, which gets cemented onto the end of the thigh bone. A new metal cap gets cemented onto the top of the shin bone. And you can see there's a very small post that goes in that cap, and that helps prevent it from rocking and gives it extra stability inside the bone. A plastic liner then snaps in between. And what's not shown here for illustration purposes is the kneecap. You keep your own kneecap, and we, again, just shave off the damaged cartilage on the undersurface of it and replace it with a plastic button. So that surgery takes right around an hour. Typically, patients are going to go to the recovery room immediately after surgery. What I did not say is the vast majority of patients get what's called spinal anesthesia, which means you have, you're not heavily sedated. You're still asleep for the surgery, but you don't require heavy narcotics or sedatives. So you're able to very quickly wake up and recover, which means you're able to get up and walk within just a few hours of surgery. Typically, most patients, again, are up and walking the same day. A small subset might go home that same day, with the majority going home just the very next morning. And typical follow-up is within the first few weeks, again, a month or two after surgery. And then we monitor our joint replacements annually through the first year, and then every 5 years thereafter, just to make sure that the joint replacement continues to function well. So we use technology to help make the placement of the knee replacement more accurate. What we use, it's called Visionaire, and that's a patient-matched technology which takes a very special MRI scan along with a special X-ray of the damaged knee. And a computer, working with an engineer, customizes implants. And as you can see, these things that look like they're on the end of the bone, they literally fit onto the end of each patient, just like a puzzle piece. So they're made exactly for that person. Their name is actually printed on it. And prior to ever entering the operating room, we know exactly what angle everything is going to be cut at. We know what size implant that the patient will need. And it's made to provide a very customized knee replacement. In fact, this technology, when it came out, if those of you are familiar with, there's a show called How Things Are Made. The technology, when it was new, was highlighted on that show because it was something just very new that made headlines in that respect. So this is kind of what the engineer might see on his end as in the computer as they're working to make these implants. They're basically making a 3D rendering of your knee within the computer to create these. And again, a lot of this allows us to preoperatively know exactly what kind of knee replacement you're going to need and how we're going to place those parts. It helps us save time in the operating room because we're not having to, in real time, make those measurements. It reduces the time at which you're under anesthesia, which can lead to lower risk for infection, lower surgical times, leads to all less complications, lower rates of blood clots or what's called DVT, quicker recovery, those types of things. Is there anything else you'd add to that use of technology, Dr. Ryan?
Well, I would just add, so when Kelly was referencing earlier that, and when we were introduced, what we offer is minimally invasive surgery. This is part of that. So by using this type of technology, we can avoid a large surgical exposure. We don't need to violate the canals of the femur or the tibia, which is typically done in a traditional knee replacement. So we're less impactful on the knee overall, therefore less invasive, and that's how we're defining that type of surgery.
Yep. So looking then at hip replacements, and again, as we discussed earlier, the hip is a little bit different joint. It's a ball and socket. So with this, though, the damaged parts are being removed. In this case, we are making a cut right beneath the ball to remove that damaged ball. And then a metal stem is placed down inside of the thigh bone in order to hold the new ball of the ball and socket. And with this surgery, the socket is placed in such a way that the bone grows onto it over time. And in most cases, the thigh bone piece is actually placed in such a way that your bone will also grow onto it with time. That means that as the weeks go on and this becomes, your bone grows onto it, these parts literally become part of your skeleton. In patients that have very poor bone quality or they're at high risk for fracturing, we use cement to hold the thigh bone piece in. That's been shown to have less complications in those people that have very fragile bone. So we do utilize that when it's necessary. In terms of walking through the surgery, again, as you can see here, that cut has already been made, that damaged ball has been removed. Within the socket, all the bad cartilage is scraped out. Any bone spurs surrounding that socket are all removed. A new metal cup is placed, and then a plastic liner can snap in between. That thigh bone piece is then prepared and placed within the thigh bone or femur, and then a new ball goes on top. And we'll talk about what these parts are made of in just a second. And that creates the new hip joint or the new ball and socket. So again, there's the cut. There's the components and the new hip joint. Very similar to a knee replacement, you go to recovery right after surgery. You're going to get up and start walking within a few hours of the procedure. Again, some patients may go home the same day, with the majority going home the very next morning. And follow-up is, again, within the first few weeks of surgery and then the first few months. And again, that annual follow-up followed by maintenance visits every 5 years thereafter. Again, we use technology to help improve how we perform joint replacement. We use computer navigation, and this kind of gives you a little bit overview of what the surgeon might see in terms of how they're placing these parts. We also provide anterior hip replacement. And anterior hip replacement is done with a live intraoperative radiograph, so we're actually looking at the parts when they're placed. And this helps us put the components in a very accurate and precise way. Again, Dr. Ryan, is there anything you'd add to either hip replacement or the use of technology and what we're utilizing?
I would just add that, Kelly's given a very general overview, but there are lots of subtleties that we have at our disposal. There are different types of bearing surfaces, ceramic hip replacements, dual mobility hip replacements. There are a number of different brands that are available. These are all things that some patients may be aware of, others may not be, others, some want to learn, some don't. So if, during the first patient visit and encounter, we can discuss any options with anybody. Kelli and I are both familiar with pretty much everything that exists in joint replacement around the planet. So there's nothing we're not familiar with, there's nothing we haven't studied, and we've chosen what we have for very specific reasons, because we believe the medical literature supports its use, is the most effective, and in our hands is the best for patient outcomes.
Yeah. So going a little bit more into implant longevity and what they're made of. So the traditional types of material that most of the bearing surfaces, and when I say bearing surface, that means the parts that rub together, are made of traditionally is a cobalt and chromium alloy. And that's this typical highly polished silver metal. It's been used for decades in joint replacement. It's tried and true. It's tested. We know that it works. We know that it lasts. A newer, it's not so new anymore. I guess we're probably getting towards, it's almost been out for the last 20 years, but a material called oxinium, and that's an oxidized zirconium. And that provides it's also a metal. It's highly polished and extremely smooth. And it's safe for those with metal allergies because it's not an alloy that contains any significant amount of nickel. And that's something that we offer here through the implant manufacturer that we use. And I'll talk a little bit more about that in just a second. And then the other piece that is used is plastic. And the plastic is called a highly cross-linked polyethylene, often referred to as XLPE, cross-linked polyethylene. It's more highly polished and harder than conventional or traditional plastics, which may have been used, anywhere from 15 to 20 years ago. And that's probably one of the biggest improvements in implant technology that we've seen, is the plastics have improved so much that the typical wear that we used to see is just not happening as frequently anymore. And I have a picture of that right here. This is an old plastic and knee replacement. Again, this is not the highly cross-linked. This is one of the older types. And it wore out, and it caused a big problem. And the reason that the joint replacements don't last forever, particularly in the older plastics, is because as that metal rubs against the plastic, it makes microscopic particles. And the body doesn't like that, and it reacts to them with an inflammatory process. And then those cells irritate the bone and tissue, and they disrupt the bone implant interface, and it can cause them to loosen with time. So one of the biggest things that we've seen in the last 2 decades is that as plastic technology has improved, we see less particle debris being created, and as such, we've seen less wear, which translates into hopefully these implants will last several years more. So that is the solution essentially, is use better materials. So what we're using again is the oxinium. It is a metal, but because of the oxidized state of the surface, it takes on the low friction characteristics of a ceramic. What that means is it's just very smooth. It becomes 49 times more resistant to the metal abrasion that's seen with typical components. So based on that, they see that it decreases that wear by 85%. It's pretty significant. And so these implants are really appropriate for highly active people or much younger patients, because if we can improve in a 48-year-old, they can get another decade out of their knee replacement. That's incredibly meaningful for the lifetime of their joint replacement. Again, this is in combination with the highly cross-linked polyethylene. And in the manufacturer that we use, this is called the Veralast technology. That's the combination of oxinium with the highly cross-linked material. And these are actual pictures of the implant. The oxinium metal is actually black. And for a short period of time, actually, I think it's moved away, but Huacheng used to actually make the raw material for this right here in our community. I think I was just told they're no longer doing that, but for those that are familiar with that company, a lot of the raw material was actually coming from Albany, Oregon some years ago. So with studies done on this, when they look at thousands of these joint replacements that were put in it's called registry data, this particular combination has had the highest survivorship of all bearing categories, and that's looking at all manufacturers at 10 years. So after a joint replacement's been in for 10 years, 96.6% survival rate, meaning that's less than 5% have failed at that juncture. In the lab or the simulator tests, again, not in a person, but in a test that's been running for years and years, it's replicated the average steps that a person would do in 30 years, and it shows that it does not have significant wear even at that amount of use. So again, something great for younger, more active patients to help increase the survivorship. And then anyone who has metal sensitivity, it's also a great solution because it does not contain any of the typical nickel and metal alloys. So what we want to also touch on is our program, not just what we offer technology, but what the actual hospital and our colleagues, nursing staff, hospital staff are doing to make this a really great experience for those that choose to have a joint replacement. So last year we achieved our initial accreditation for DNV certification. And again, the DNV is what certifies the hospital. It's being a legitimate hospital, and they have sub-certifications, and one of which is in joint replacement. So we're one of 2 hospitals in the state of Oregon to have this designation as a center of excellence, and it recognizes what we've done to improve patient care, the quality of our service, and as well as our outcomes. And we just underwent our 2nd accreditation and were approved for ongoing accreditation. That was actually just this week. We got word back that we were reaccredited for this year. So it's a big accomplishment. It's a huge undertaking for our hospital and a sentiment to how dedicated our staff is to our joint replacement patients. So patient experience is a huge part of this. And we want this to be a good experience. We want people to choose to come here to have this done. So once a patient is scheduled for surgery with us, the path to get from that first consultation to your actual surgery and home is very streamlined, and you're at the center of it. We have a care coordinator that works just at being available to answer questions and make sure that everything is set up and streamlined for you to get your joint replacement done. Each patient will undergo extensive medical clearance. We take the risk of surgery very seriously, and we want your doctor, your primary care doctor, and any other specialty providers to be very involved in your care to make sure that your risks are minimized undergoing a major surgery. All patients go to an education class, which is taught by a nurse at the hospital, along with therapists, discharge planners, and even pharmacists to help streamline your recovery and make sure that you know everything you need to know about being prepared to undergo joint replacement. And then within the hospital itself, we have a dedicated joint replacement floor with private rooms. All nursing staff is specialty trained. All of the ancillary staff are all trained specifically in caring for joint replacement patients. Every patient that has surgery has individual rounding where we sit down one-on-one and we get their feedback, and we want to know about their experience and how, if we can, how can we make it better. And discharges are streamlined and individualized for each patient to make sure they have the things that they need for home. And we just wanted to share, every month we collect feedback from patients, and the feedback is typically phenomenal, and it makes us feel good about what we're doing. So I just want to share a little bit about what some patients, these are direct quotes from people. I can't say enough about the doctors and staff. I've had many surgeries, and this was the best care I've ever had. The staff bent over backwards, and that really is a testament to how great our nursing staff is that cares for everyone. I've been so happy. Best hospital food I've ever had. I eat at the hospital all the time. I'd say they do a very good job. That's true. You know, they all did a great job. The care was great. Exceptional staff, amazing care. These are the things we hear day in and day out, and that we're proud to be a part of, both Dr. Ryan and myself, about the dedication that our team has, not just in our office, but at the hospital. And our team, these are our core team. This is not everyone involved, but Dr. Ryan and myself, and our assistants, Eric Moen, Dr. Ryan's PA, and Tina Williamson is my nurse practitioner. And then we have our care coordinator that I mentioned, Maddie Sadowski. Carrie Ballinger is Dr. Ryan's nurse, and Casey Kazmarek is my assistant. This is where we direct people for more information. Our website is very informative, and information is added to that monthly. And then the number here to call for more information. And that typically you can actually speak with Maddie if you have further questions about the program. Is there anything else you'd want to add, Dr. Ryan?
No, I think you did a great job. That summarizes things well. You know, the effort to become certified in this way, you know, it's been a really colossal effort, and I don't think I can compare it to anything I've been a part of within the Samaritan system. You know, the Albany Hospital in total basically agreed to tackle this project. It's been years in the works. The hospital administrators, the nurses, discharge coordinators, physical therapists, imaging services, pharmacy, anesthesia, everybody has been sitting down at the table together to coordinate, to learn, and to make this program as mature and as developed as it is. And we really see it with respect to our patient satisfaction, our outcomes. We're really performing at the highest level of joint replacement. And having trained at an institution that is, world renowned, I can tell you that the experience that our patients are having here in Albany it's beyond and better than what patients over there are experiencing. It's really outstanding.
And so with that, we'd like to open up. If anyone does have a question, feel free to just throw it in the chat, and we'll go over those. You don't have to wait. You can just type it in, and we'll do them in the order that they that they come up.
I'll answer the first question, and that was pretty a bit higher up in the chat. It says, I've been told that I need a total knee replacement, but I weigh over 300 pounds, so they won't do it. I should exercise to lose the weight, but I can barely walk, let alone exercise. Is this a new rule, or can a provider use their own discretion? So this is a very common topic. I often tell my patients, I talk about 3 things in my practice: knee replacement, hip replacement, and weight. We have a population that is getting heavier in the United States, and we know that increased weight is leading to increased rates of arthritis. This is not disputed. This is a fact based on well-done medical studies, and we know that knee replacement in particular is really increasing quite rapidly. So currently, and what most providers know, and this includes primary care providers and physical therapists and things like that, the current recommendation by the American Academy of Orthopedic Surgery and the American Association for Hip and Knee Surgeons, both of which Kelli and I are members, they do not recommend moving forward with joint replacement if a person has a body mass index of greater than 40. And the body mass index is a ratio of height and weight and is an indicator of how heavy somebody is. So this puts us in a tough position. We have a solution to knee arthritis, but we have recommendations that say you can't do it on the patient population that's developing it at the fastest rate. So this is not a hard and fast rule in my practice. This is a guideline. I operate on patients who weigh over 400 pounds, but each decision is made on an individual basis. What's most important to me is not the person's weight. That is one factor. More important is where the weight is located. If that weight is located over their hip, where we're going to do a hip replacement, or right at their knee, where we're going to do a knee replacement, then we know from medical studies that there's an increased risk of wound breakdown, wound healing problems, and infection. And all of those things can lead to devastating complications. Also, technically, the operation is harder to perform, and placement of the implants can be more challenging, and other complications can also arise. So given that, each person needs to be addressed on an individual basis, and I go to lengths to describe what options might be available for weight loss, if that is the best course, or allowing the person who is heavier, who wants to have a joint replacement, that they are at increased risk and they need to accept that risk before we're moving forward. Anything you want to add to that, Kelli?
No, I think the other piece that comes with, as people, we do see a heavier population that also tends to come with other medical problems such as diabetes, heart conditions, and so we do have to look at the whole person. And there can be very healthy people that are overweight, and they might be at a lower risk than somebody that has poorly controlled diabetes and heart problems along with being heavy. So it is a very individual thing, and we have to look at each person and their other medical issues to make that choice. So I would agree with what you said there. we can go on. The next question was, in your opinion, does collagen supplementation help with recovery after surgery? I'll say that there isn't any data to support the use of collagen after surgery. We use certain supplements that there is data for. Vitamin C has been shown to have some benefit. Vitamin D has been shown to have benefit, and we encourage all patients to take those medications in the recovery period. That being said, anecdotally, I hear that collagen is very effective in managing things. So I will say that it won't hurt in the recovery process, and those are supplements that wouldn't interact with other medications you'd be taking. Those would be very safe to take afterwards. But there isn't really any data to show, or any long-term studies to show the efficacy of that.
And I'll add, there's been a lot of discussion about collagen in the popular media as of late. And interestingly, one of the individuals who helps Kelli and I with surgeries, she's been a part of my practice for 12 years. She's was previously a general surgeon. She acts as one of our assistants. She has been very pro collagen for decades. And, the thought being, you're healing, your body needs new tissues to build. If you have adequate dietary intake of collagen, therefore you will repair your wound better and you may heal faster. It certainly makes intuitive sense. And she's been very insistent, and she used it in her practice. I have been looking at the literature, and as Kelli indicated, it doesn't indicate it, but that doesn't mean it's not true. Maybe we just haven't found that relationship yet, or somebody didn't do the right study yet. So if this is something you're considering, I would certainly encourage you to do it. I've taken collagen supplementation myself, and I think it's worthwhile exploring.
So the next question, I live in Newport, about how many trips will I have to make to Albany? Any future plans to do surgeries in Newport? So that's actually a great question. I can say to the second part, because of the logistics of doing joint replacement, performing them in Newport would be very difficult at this juncture. But we have a lot of things coming, a new telemed system to help increase access to care to those on the coast. We are happy to do as many visits as possible via telemed for our patients on the coast. We've even done, especially when COVID first came on, we were almost forced to use the telemed system for postoperative visits, and we found it actually was very effective. We can look at patients' incisions via the video format, and so we offer that to as many visits as they'd like. Physical therapy can be done in Newport. A lot of the imaging, preoperative lab work can be done in Newport. The actual surgery would be a trip, and sometimes one pre-op or maybe even one in-person post-op visit, but we could minimize those as much as possible to make access to the surgery much more manageable. Is there anything you'd add to that, Dr. Ryan?
That's great. Everything Kelli said is spot on. We, over the past, decade plus, I've operated on countless patients from the coast. And, right now where our practice is, we're better positioned to make it convenient and as reasonable as we ever have. We're very familiar with all the physical therapists in the area, the processes, the primary care providers, so it can be done very well. And we operate on patients not only from the coast, but also from Salem, from Portland, from Klamath Falls. I mean, I've had patients come from other states to have surgeries and then recover here and then fly off to wherever they happen to live. So we're pretty facile at getting things accomplished at a distance.
And then the next question, what's the maximum level exercise that can be expected after knee replacement? Running, cycling, weight training? You want to go ahead and answer that one, Dr. Ryan?
Sure. So it depends. So the way I like to address this question is, you may feel like you can do whatever you like, but it's about using common sense with respect to understanding that what you are doing is going to affect the longevity of your implant. If you place an implant in a person who weighs 150 pounds and has a very average lifestyle, meaning, normal recreation and, working around the house, this implant, we can hope for 20 years, or we can expect 20 years and hope for up to 30 years. If you are heavier, if you are going biking and running and you are, doing very extreme activities, skiing 20 to 40 days a year, we know that this taxes the implant and that can lead to premature failure. So the point of this surgery is to improve quality of life, to allow people to get back to what they want to do. And so everybody will make their own decision based on, what they want to do and how that could impact the need for a future revision down the line. So I don't like to tell people how to live their lives, but allow them to understand that what you're doing does have an impact. I have patients who are, it's interesting, I have a patient who was actually the US record holder for squats and some deadlift things. He's a power lifter in the past, and he enjoyed doing those things. And I've had a number of patients who have been weightlifters, and they want to know if they can go back to lifting those extraordinary weights, hundreds and hundreds of pounds. And they certainly can, but they're not doing themselves any favors in the long run. Keeping the loads a little bit lighter, maybe some higher reps, that may be a better way to go. So things to think about. I need to have, it looks like there's a follow-up. I need to have both knees done at the same time, spread apart. So I do, and Kelli also does what we call simultaneous bilateral knee replacements or hip replacements. That means having both sides done in the same anesthesia, the same surgery, same day. And that, in my opinion, there are great candidates for that type of surgery. There are others who may think they're great candidates but aren't. It's much more challenging. Everything's more painful. There's a lot more rehab involved, and it can be very challenging. So you really have to want it. You really have to be invested in the process and then in the recovery, have help that's available. But for the right patient, it can be a very good solution. That said, if you decide to just have one at a time, then separating them out in time by about 3 months tends to be the best and what I usually recommend. Kelli, anything to add to that?
I'll say with doing both joints at the same time, there's actually a pretty significant increase in medical complications. Cardiac events, blood loss is quite significant. And so in order to have it done, I think actually very few people meet criteria, because you have to be in exceptionally good health to undergo not only one major operation, but two at the same time. So it's very rare that people actually are medically well enough. A good majority of our population is in their 70s and 80s, and with age comes some medical complications. And so I think it's very rare, and it has to be very much the right patient, which I think is what Dr. Ryan was alluding to. So, but knowing that there are significant medical complications that come with doing two at the same time.
Will this, let's see, how to decide whether knee replacement is appropriate? So that's a good question. A lot of patients ask, well, when is the right time? How do I know this is what I should do? And at the same time, a lot of people will say, I've been told I need a knee replacement. So to start, nobody needs a knee replacement for the most part. This is not a cancer. This is not a tumor. This is not a life or limb threatening problem. The problem is with quality of life. And only a person who's suffering from that condition can really determine as to whether or not they want to go through the surgical procedure in hopes of improving their quality of life and accepting the risks associated with the procedure and accepting the work that's associated with the recovery. So it's an individual decision. Our job is to inform a person what the status of their joint is, what their options are, the pros and cons, and allow that person to make the best decision for themselves. That said, generally, Kelli and I have an impression of when it's the right time. And generally, if your activities of daily living are quite miserable because of that pain, if you wake up in the morning, the first thing you think about is, how am I going to get through my day because of this pain? And if you have pain that wakes you up at night and your sleep is disrupted because of pain, or you need to take medication to help you sleep because of pain, those, and assuming you've tried several of the non-surgical treatments, and despite that you still are experiencing that disability and that those ill effects, that's generally a good time to start considering it. Age is also a big factor. If you're 20 years old and have this problem, it's a different discussion than when you are older. 67 years old is generally the average age that a joint replacement for a hip or knee is carried out in the United States. So this is something to keep in mind as well. If you have this before that time, in your late 40s, 50s, then you can expect to need a redo surgery because of failure of that implant at some point. If you are 90 years old, there's a pretty good chance that the one surgery will be enough, unless you live till 130, and that's not very common. So these are also things to keep in mind. There's also medical literature, and which we do review constantly, that if you wait too long, you might not necessarily be doing yourself any favors. As everybody gets older, our general health does deteriorate. If you are healthy and raring to go when you're 75 years old, there is no point in waiting until you're 80, because something might have happened, and you might think, wow, I should have done this sooner because it would have been safer and it might have been easier to recover. So these are things to keep in mind, and things that Kelli and I discuss with each individual to help them make the best decision for themselves. Kelli, anything to add?
No, I think that's absolutely right. I usually tell people there's three things that, is it affecting your quality of life on a daily basis? Is it affecting your ability to do things that you enjoy? And is it decreasing, your ability to do basic activities of daily living? And that would include sleeping. And if your answer is yes to those three questions, most people, assuming that you actually have, you are a candidate for the procedure. That's kind of the questions that I go through to help people come to that decision. But ultimately, it is elective, and it is up to you as a patient if it's right for your life.
The next question is, will this presentation be available to review later? It looks like Jennifer did add that that is being recorded and will be sent to all participants. Thank you for answering that, Jennifer. Kelli, you want to take the next one? How long would one expect to have relief from hyaluronic acid injections?
So hyaluronic acid injections are much less predictable, and actually there's newer literature that shows that in some studies these are equivalent to an injection of saline. So the data on them is very, very mixed. I will say anecdotally, I've had patients get hyaluronic acid injections that last a few days. Some people get 6 months. So it's very, very patient dependent. With most injections, I think a good outcome, I would say, is 3 months or more of relief. That would be the case with hyaluronic acid or corticosteroid injections. But it's very, very dependent every patient is different in their response to these injections. Did you have something to add to that?
No, I was just going to say I've been performing those injections for over 20 years now. Half of the patients find them to be very helpful and do something. Half of the patients don't think they do a single thing. So it's really hard to predict. Impossible.
Flip of a coin.
Receive benefit or not. That said, if the arthritis is very severe, they really don't do anything. If it's on the mild to moderate side, then they can be more beneficial, and the chance of success seems to be a bit better.
I agree. Yeah.
Go ahead.
Go ahead. Health insurance a factor in whether or not you perform surgery? Absolutely not. Say Dr. Ryan and I both work for Samaritan, and I could say when people come through the door, I don't even know what insurance they have. So we're happy to help whoever has this problem. And Samaritan does have a great support system for those that do have financial issues or things like that. They do a lot for the community to help provide these services because they can be costly procedures, but Samaritan has a lot of assistance out there for patients that do need it. So does AGH have a dedicated operating room just for joint surgery? Does this lessen infection? You want to go with that, Dr. Ryan?
Sure. So as joint replacement surgeons, we use a lot of equipment. We use more than virtually everybody else. So the larger operating rooms are pretty much reserved for us. Monday through Wednesday. So Kelli operates on Monday and Wednesday. I operate on Tuesday and Wednesday. So we have certain rooms that are reserved specifically for us, and we operate in the exact same rooms every week. That said, those rooms are available to other surgeons at the times when we're not there. Does that change the infection risk? No. There's no literature that indicates using a room for something other than joint replacement would therefore increase the risk of joint replacement infection when those rooms are used for those purposes. We have tremendous staff that turn over each room, which means they essentially re-clean each room in a very impressive way, in between each surgery. So we have no concerns about any sort of carryover contamination. That said, our infection rates and our complication rates in general are extraordinarily low. They're much lower than national averages and world averages across the board. So we're doing pretty great in that respect.
Let's see, where is the cutoff? Where is the cut in the body of a hip replacement, and how long is the recovery? So hip replacement, it actually depends on the type of hip replacement that you'll be having. For myself, I perform the vast majority of my standard hip replacements are what are called anterior. And that means the incision is sort of to the front side of the thigh. The other common way of performing hip replacement is what's called a posterior hip replacement. And that's Dr. Ryan performs posterior hip replacements with computer navigation. And that's an incision that sort of comes off to the side of the buttocks is the best way to describe that. And recovery for both of these is actually very, very similar, regardless of where the surgical incision or what we call the surgical approach is. Both types of surgeries, whether it's anterior or posterior hip replacements, you're up and walking the very same day. Again, discharging typically the very next morning, some people going home the same day. People can expect to be on a walker, some people for a few days, some people for within the first 1 to 2 weeks as they transition to a cane or some people to walking sticks. You get into physical therapy right away. I tell people the short recovery is usually in those first 4 to 6 weeks where you're getting back to activities that you enjoy, light walking, some people doing some light work in their yard or garden around 4 to 6 weeks and returning to activities. Typically, for me, between 8 and 12 weeks, I start releasing patients to mostly full activities. I say by around 12 weeks, consider yourself about 90% recovered. That last 10%, as we know in the data, will come over the course of a full year. We consider patients fully recovered at 1 year. Some people will keep improving for 2 years after a joint replacement. And are there anything, other details to that you would add, Dr. Ryan?
So when it comes to the approach to the hip, that is a common topic of discussion in popular media and so forth. And everybody seems to think that there's just 2 ways to go into the hip, and there are actually 5 common ways that surgeons will perform a hip replacement. We've talked about anterior, posterior. There's also the direct lateral, the anterolateral, and the superior approach to the hip. And every surgeon will have their reasons for choosing one over another. And this is not something that's very clear to patients because they might not know, well, which one should I have? And this is not something that has been established. One approach has not been established to be superior to others. And this is debated with surgeons around the world. Everybody is sits in Zoom meetings like this and presents their data and their results, and then and they argue back and forth, and we argue with them about what we think is the right way to do it. So the bottom line is that in contemporary hip replacement, majority of surgeons are doing things very well. And what our medical literature has made very clear, and this is not disputed by anybody, and the approach that the surgeon is most familiar with and most comfortable with is the best approach for that provider and for that patient. So what we don't want to see is a provider changing approaches to accommodate somebody's wishes or and do something that they're not familiar with. So that's the most important thing. And when it comes to just surgery in general, the number of cases that a hospital is doing, the number of cases that particular surgeon is doing, you want it to be high. And then this just makes sense. If you take your car to an auto mechanic and they tell you, wow, that's the first Ford I've ever seen in my life. I guess I'll figure it out. you probably would be better served by taking it to a dealership who's, says, we do this all the time. This is bread and butter. I could do this with my eyes closed. So these are just some of the things that get brought up frequently. It looks like there's some hands up, and I wanted to give James a chance to ask his question out loud. So you're on mute right now, James. If you could unmute, that'd be great.
Yeah.
Okay. How does the hip replacement connect to the existing bone?
So the metallic parts are generally made of titanium. So the cup that we see here is made of a titanium alloy, and that surface has been recognized to be extremely bone friendly. So the bone will grow onto and into the implant. On the femoral side, we have again, either a titanium stem that has that top coating on it that allows the bone to grow onto it, or as Kelly was referencing before, we use bone cement to hold the implant in place. And in bone where the integrity is not as good, it's a bit softer, the bone cement has been shown in medical studies to be superior in the long run, preventing problems and especially fractures even up to 10, 15 years down the line. So that's how those implants are secured to the bone. Does that make sense?
Yes.
Anything to add, Kelly?
I think sometimes people think too, how does it not just fall out? And the thing that we don't show in all these pictures is you've got a very robust capsule that connects from around the pelvis down to the thigh bone. And then you have muscular attachments from the pelvis down that hold the ball very, very tightly into the socket. And so by restoring your anatomy appropriately and making sure that we keep your leg length the same and the position of the hip joint the same, it maintains those muscular forces that holds the hip in the socket very, very tightly. So it doesn't just fall out, so to speak.
So should all options be tried before replacement surgery? So that's a great question. There are, we've outlined a number of options. Some people try all of them and want to postpone surgery as long as possible, and oftentimes that's the right answer. Some just try a few. There are individuals who are petrified of needles, and just the idea of having a needle in their knee while they're awake is very scary, and they're not interested. So we don't force these types of treatments upon individuals. So it really is based on each person, their preferences, and their life situation. That said, insurance companies, as we're all aware, have increasing control over how medicine is practiced, and there are some insurance plans and some insurance companies that do insist that non-surgical treatments are implemented prior to moving forward with replacement. And every insurer is different. Some may require an injection, some may want physical therapy or weight loss. We have seen denials because of weight. So all of these things are kind of in flux, but hopefully that answers your question for the most part. Kelly, anything to add?
No, I think that's exactly right. Next question, what is the typical performance after knee replacement? I'll try to answer this, and John, you can tell me if this isn't what you were thinking, but for the most part, after knee replacement, patients can expect to get, if they work hard with therapy, full extension of their knee. About the average amount of bend is 120 degrees. So if sitting is 90, you can imagine the knee going beyond that. Typically, most patients don't get their heel back to their butt if they were able to do that prior to surgery. In terms of performance, patients with knee replacements can hike, bike, walk, swim, do all types of recreational activities. There are a subset of patients, though, that will experience stiffness after knee replacement. There is a subset of patients that don't like their knee replacements or have some residual swelling or discomfort after surgery. It is not 100% satisfaction rate. There's nothing that we do that is. And there is, with knee replacement, I tell people this all the time, there's some expectations that it's not restoring the joint that you had when you were 20, but it truly is a replacement. The parts are metal and plastic. They click, they pop, they make noise. And for the most part, there's typically a general awareness that that's your replaced knee. It's a different feeling than a native knee. So hopefully that answers the question. If there was anything else there, you can go ahead and add to it. But that's what I tell people to expect.
Yep, I think that's sounds good, Kelly. The next question, I already have a surgery date set. Are the x-rays and MRI scheduled to be performed close to the surgery date? So we have a surgery scheduler, and Maddie, who's our coordinator, she will arrange that at the appropriate time so that those can be done in order to fabricate that customized instrument that's used for the knee replacement. If I'm assuming you're referring to a knee replacement, if it's a hip replacement, then then that's not required. So hopefully that answers the question. It looks like Joy McDowell's had her hand up for a little bit. Joy, can we answer your question now?
Yes, I'm 82 years old. Am I too old to have a hip replacement?
I hope not, and don't ask that to my 95-year-olds that we're doing, within the past week or two. So there is no age that is a limitation. I've done these operations on people as young as 14 and over 100. So what's more important is your body able to tolerate the procedure? And for the most part, it usually is. Even if you've had other medical conditions, that you may be receiving treatment for, we have a very comprehensive system within Samaritan where we'll have you see other doctors who may be involved with your care. We may have, we'll may have some other testing on your heart or things like that. So there is no age that's too old. In the past 12 years since I've worked for Samaritan, I've not moved forward with surgery because of medical conditions on less than 5 patients. And those patients were aware that if they were to move forward with it, it may not end well. And these are discussions we have with each person as an individual as well in making the correct decision. Kelly, anything to add?
No, I absolutely agree. It's the old saying, age is just a number. That's true in this respect as well. It really depends on your overall health, your ability to recover, what's your support system like at home to go through a big surgery and recover from it. And I think it really just depends on each individual.
It looks like the last question up is, I have limited range of motion. Do you do shoulder repair or replacement? So I'm assuming limited range of motion with the knee, or the hip.
I think they mean the shoulder.
If it's the shoulder. So with respect to shoulder, we have, so Kelly and I, we do not do shoulder replacement or shoulder surgery. We are hip and knee replacement surgeons only. We do have 2 providers within the Samaritan system that specialize in shoulder replacement and in shoulder arthroscopy, and that includes any sort of repair that you may be referencing. We have a provider in Albany. Her name is Dr. Lauren Hansen, and she's been with Samaritan for about 5 years now. And we have a new provider who is just starting right now in Corvallis, who is his office is based in Corvallis, and he'll operate in Corvallis. His name is Kai Mirsch. He's been in practice for 16 years, and he recently left his practice in Virginia and has joined our Samaritan team. One of the other roles I fill within Samaritan is the director of orthopedics. So I was involved in the recruitment of him to Samaritan. He's a tremendous individual. He's very experienced. He's done countless shoulder replacements and shoulder surgeries. So we're glad to have him on our team. We also have another provider that specializes in arthroscopy or shoulder repairs, and that's Christopher McCrum. And he was recently recruited to our hospital as well. He's coming from Texas. Very great individual, and we're happy to have him on our team as well. So all 3 of them do shoulder arthroscopy and repairs. Dr. Mirsch and Dr. Hansen do shoulder replacement. So limited range of motion is often true of any arthritic joint, hips, knees, shoulders. So that is expected with joint replacement surgery. So it likely will not be prohibitive moving forward, but that obviously, a physical exam and discussion with the surgeon would need to be undertaken.
Did you have another question, James? Your hand is up again.
This is Maxine.
Hi.
Dr. Baum, were you showing slides or pictures earlier in your presentation?
I
We
was.
weren't getting, because we weren't getting any of that.
Nobody was, huh?
I don't know if the other people.
No,
I
we
can
were
see that.
seeing it. Yeah.
Okay.
Oh, well,
So
Sometimes,
we didn't have
I'm sorry, sometimes within your format, you can actually click out of that shared image and then you're just looking at people or the quote box. So you may have been in the wrong screen. I think the presentation will be available if I'm not correct, Jennifer. And we could send out the PowerPoint to those that registered if you wanted to.
sure. Yes, it has been recorded and we'll send that link out, and then we can also include the PowerPoint presentation as well.
Sure. Yeah.
Thank you.
Sorry about that.
The next question is how far in advance are surgeries scheduled? And then the subsequent question, how far out are surgeries being scheduled now? So along the same lines. So both, we have a great program. There, Kelly and I both have wait times to be seen. I'm going to speak a little bit about something we haven't discussed yet, and that is our non-operative team. So we have a group of providers at Samaritan. They're called, they're non-surgical family practitioners who have done fellowship training or advanced training in care for musculoskeletal health. So they specialize in all the non-surgical treatments that we were referencing. They do all the injections, they can set up physical therapy, they're experts at bracing, and they know all of those treatments. Their wait times are quite low, so you can generally get in to see them within a week or two. So you start with those providers. Then if they decide, or as a patient decide with them that you would like to consider joint replacement, then they refer to us, and they have a much easier way of getting a patient referred to us than a primary care would. We do not review any of their referrals. They automatically are sent to see us. So that said, Kelly and my wait times right now for a new patient visit are typically around 4 to 8 weeks. And then once we see you, we start the process if we do move forward with surgery. And that can take anywhere from a few weeks to up to 3 months. And it depends on the surgery. If we are moving forward with a knee replacement, then the wait time is a bit longer. We need to get the MRI scan. We need to fabricate the customized instruments. That can take a little while, and coordinating with your other providers. If you're very healthy and we've decided to move forward with the partial knee replacement, oftentimes we can do those a bit sooner and within sometimes 3 or 4 weeks. That said, we are pretty busy, and our wait times and our surgery schedules fill pretty quickly. So hopefully that answers your question. It's a hard one to say with certainty because it's kind of dynamic and it depends on a variety of factors. Anything to add?
Yeah, I think our wait times currently too, there's been and their next question is about COVID. There's been a little bit of some impact from COVID where patients were obviously not coming to get elective surgery. And so I would say, particularly this winter, we've had a huge influx of people wanting to, starting this summer to get their surgeries done because they delayed actually through the shutdown with COVID. And so our wait times now are actually particularly longer than usual. And that also is the case a lot of times in winter as well. People are going to be inside anyways, so the winter wait times get longer. So some of the wait times are very seasonal. And then on that, the next question was, how does COVID impact elective joint surgery? Currently, we are very fortunate that we have not had to shut down our facilities, but the facilities to the north and south of us have stopped doing elective cases. Right now, we do a lot of preventative things. Those that are, we're recommending immunizations, obviously. Those that are not immunized have to undergo COVID testing pre-surgery. The risks of surgery, I think, related to COVID, because there are more COVID patients in the hospital now than we've ever seen in our community. That relative risk of contracting COVID is probably higher. But I think at this point, we're sort of on a week-to-week seeing if our hospital will be affected by shutdowns And again, Dr. Ryan may be able to speak more to that is in his director role, kind of what the future would look like with regards to that.
Diagrams.
You're on mute, Dr. Ryan.
Sorry, I think I just muted myself. This is something that's on my, daily routine of, I meet with a lot of the hospital administrators, the system administrators, discussing where Samaritan is with respect to closing the operating rooms. Good Samaritan Regional Medical Center has seen cancellations of joint replacement surgeries because of shortages of staff and the inability to provide the appropriate care after surgery. Albany has not experienced that yet. We may. It's impossible to know. As Kelli referenced, we've seen shutdowns in Bend, in Salem, in Eugene. Those, Portland, certainly they're not carrying out as many elective surgeries in general, especially joint replacements. We're trying to keep things going as long as we can, as long as we think it's safe. But this is a very real problem. We shut down for 2 months in 2020. That may happen again. We just don't know. And as Kelli indicated, if you have the COVID vaccination, you do not need to be tested. We are questioning whether or not we will be testing everybody as we had in the past prior to a large-scale vaccination. A meeting this past Wednesday indicated that we would not be doing that as of yet, because we don't want to overly test, because our testing capacity is not it's reaching its limits as well. So all of these things are really dynamic and changing in real time as we speak. So we can't say with certainty how things will be in the next week or month or two. Any resources, papers, websites you recommend for education about knee replacement? There are countless resources out there. I generally.
The screen that I shared? Or can you see the screen that I shared? This website?
Yes. Yeah,
Okay.
That's a good one. I was just going to bring that one up. So this is the American Association of Hip and Knee Surgery website. And again, Kelli and I are members of this society, and we attend their meetings and so forth. So this is exclusively for hip and knee replacement surgeons, this association, and they do publish things for the general public. So this is a great resource. The American Association for Orthopedic Surgery has similar information. The Smith & Nephew website, which is the site that is made by the company that we utilize for the majority of our implants. We don't exclusively use Smith & Nephew, but we've chosen this company because of the strength of their products. They also have information if you'd like to learn more about the specifics of the implants that we utilize. You can go to that website as well. It looks like, James, you have another question. Go ahead. James, can you hear us? You'd like to ask your question? Okay. So it looks like Kelli put on the website for the AAHKS. What about labrum tears in the hip? Is a total replacement needed? So the labrum, for everybody who doesn't know, is a structure that is kind of along the cup or the socket of the hip. That's not bony. It's not quite cartilage. It's a cartilage-like material that helps contain the hip in the socket, and that can be torn and lead to pain and disability. So if you do not have arthritis and have a labral tear alone, then hip arthroscopy, where a camera is placed into the hip and a small cleaner is placed into the hip, or a surgical tool to either clean the damaged area or to repair it, can be entertained, and that can be done. Prior to our new recruitment of Dr. Christopher McCrum, Samaritan did not offer that service, but he is an expert in that type of surgery, and so Samaritan does offer that type of surgery now. So that's called a hip arthroscopy. Now, if you have a labral tear, but you also have arthritis, then hip arthroscopy may not be the best option. It depends on the amount of pain that you have, your activity level, the degree of arthritis, the degree of labral tear. So some may be a candidate for hip replacement, some may be a candidate for hip arthroscopy, some may be somewhere in between, and we're just doing conservative measures or non-surgical treatments until hip replacement is it looks like it would be reasonable to move forward. So hopefully that answers that question. Kelly, you want to take the next question?
I think they're just
that's it. Thanks for
comments.
sharing.
Yeah, yeah.
Thank you so much. All right.
All right.
Anything else? Any hands raised? Nope, doesn't look like it.
Looks like you've answered all of the questions so graciously. Thank you so much. We've gone over time and we appreciate your time today. Dr. Baum and Dr. Ryan, thank you so much. Thank you to everybody for joining us today. It's been a pleasure to having you, and great information that was shared. As you can see, we are very fortunate to have both Dr. Baum and Dr. Ryan here in Albany and performing these surgeries. Like we've mentioned before, this has been recorded and it will be sent out in an email to all participants that registered. We will include the PowerPoint presentation that they presented today as well. Again, thank you so much for joining us. Thank you again, Dr. Baum and Dr. Ryan. This was an amazing presentation and we appreciate everything that you do for our patients.
Great. Thanks, everybody.
Thanks,
Have a
everyone.
great
Have a
weekend.
wonderful afternoon.